Welcome to Part 1 of Chapter 12, Nursing Care for Patients Having Surgery. It's page 170 of the 6th edition. Surgery is the use of instruments during an operation. It treats injuries, diseases, and deformities. Surgical procedures are named according to 1. The involved body organ, part, or location, and 2. The suffix that describes what is done during the procedure, Table 12.1. Surgery is performed by surgeons and other physicians trained to do certain surgical procedures. Advanced practice nurses with training may also perform minor surgical procedures. Surgery is scheduled based on the urgency required for a successful outcome for the patient. Table 12.2. Reasons for surgery are to be performed reasons for surgery to be performed are listed in Table 12.2 also. Types and phases of surgery. Laser, scope, and robotic techniques reduce the invasiveness of surgical procedures. Minimally invasive surgery is less damaging to tissues than traditional open surgery, incision surgery. This allows a faster and less painful recovery. Laser surgery uses a laser instead of a scalpel to cut tissue. It is often used for eye surgery. An endoscope is used for minimally invasive surgery. This is also called keyhole surgery. Minimally invasive surgery includes laparoscopic surgery, abdominal and pelvic cavity, and thoracoscopic surgery, chest and thoracic cavity. The endoscope is a flexible tube. A light, camera, and suction are attached to it. It is inserted through a small incision. An image is then projected on a screen for the surgeon to watch. Additional incisions are made for insertion of other instruments based on the type of surgery. 12.1 shows the surgical procedure suffixes, and ectomy means removal by cutting. Some examples are craniectomy, which involves the skull. Appendectomy involves the appendix. There's also orthopy as a suture or repair. And so there is cholecystectomy and heniorrhaphy. Okay, it's cholecystectomy and then herniorrhaphy. The suffix oscopy means looking into, and there's a colonoscopy which is the intestine, and a gastroscopy, which is the stomach. An ostomy is a formation of a permanent artificial opening. There is a ureterostomy, which is the ureter, and then a colostomy, which is the colon. Then there is the otomy, which is an incision or cutting into. There is a osteotomy, which is a bone and then cutting into the bone, or a thoracotomy when you cut into the thorax. Plasty would be the formation or repair. So there is otoplasty, which involves repairing the ear, and then mammoplasty, which is the breast. Table 12.2 on page 171 shows surgery urgency level and purpose. So the urgency level of emergency, the definition is immediate surgery needed to save life or limb without delay. Examples would be ruptured aortic aneurysm or appendix, traumatic bone amputation, loss of extremity pulse from emboli. So the next level is urgent. The definition is surgery needed within 24 to 30 hours. Examples would be a fracture repair or an infected gallbladder. Elective surgery, the definition is planned or scheduled with no time requirements. Examples would be fracture repair, no, would be joint replacement, hernia repair, skin lesion removal. Then there's optional surgeries, which is surgery requested by the patient, and an example would be cosmetic surgery. So there are several different purposes for performing surgery. The aesthetic purpose is defined as being requested by the patient for improvement. An example would be blepharoplasty or breast augmentation. There is a diagnostic, which is defined as to obtain tissue samples, make an incision, or use a scope to make a diagnosis. And the example would be a biopsy. There is exploratory surgery, which is confirmation or measurement of the extent of the condition. And an example would be an exploratory laparotomy. There is also preventive surgery, which is removal of tissue before it causes a problem. This would be an example would be a mole or a polyp removal to prevent cancer. There's also curative surgery, which would be removal of diseased or abnormal tissue. An example would be an inflamed appendix, a tumor, a benign cyst, or a hernia. There is also reconstructive surgery, which would be correction of defects of body parts. Example would include a scar repair, a total knee replacement, a facelift, or mammoplasty. There's also palliative, and the definition would be alleviation of symptoms when disease cannot be cured. So an example might be debulking, which would be removal of as much of the tumor as possible to relieve pain or pressure, or colonostomy for incurable bowel obstruction, insertion of gastrostomy tube to provide tube feedings for a swallowing problem, and rhizotomy, which cuts the nerve root to relieve pain. Robotic surgery, which uses robots, is growing in usage. The Da Vinci surgical system is one type of surgical robot. It has several moving arms. One arm is a camera. Two are robotic arms that act as the surgeon's hands. The fourth arm moves obstructions out of the way. As the surgeon moves the controls, the robotic arms inside the patient's body translate the movements to cut, suction, or suture. And you can visit intuitivesurgical.com for more robotic information and videos. There are 3 phases in the surgical process. There's preoperative, intraoperative, and postoperative. Perioperative refers to all 3 phases. It includes the time before, during, and after surgery. Each perioperative surgical phase has a defined time frame. Specific events related to surgery occur in each phase. In the preoperative phase, your role as a licensed practical nurse in the preoperative phase is to assist in data collection and contribute to the patient's plan of care, reinforce teaching and instructions given to the patient and family by the surgeon and the registered nurse, provide emotional and psychological support for patients and families. Other healthcare team members also assist in preparing the patient for surgery. The surgeon obtains a medical history, performs a physical examination, and orders diagnostic testing. RNs perform a preoperative assessment, provide explanations and instructions, and offer patients and families emotional and psychological support to ease anxiety. They also develop a plan of care and verify the patient's name, surgical site, along with the patient, allergies, and related information when the patient arrives in the surgical area. Table 12.3 shows the perioperative surgical phases. The preoperative phase begins with the decision for surgery and ends with the transfer to the operating room. The intraoperative surgical phase begins with the transfer to the operating room and ends with admission to the peri-anesthesia care unit, or PACU. Post-operative surgical phase begins with admission to the PACU and continues until recovery is complete. Factors influencing surgical outcomes. When preparing a patient for surgery, the goal is to identify and implement actions that reduce surgical risk factors. The focus of the preoperative care is to help the patient achieve the best possible surgical outcome. And this is done by ensuring the patient is as healthy as possible for surgery. Age. For older patients, surgery can promote quality of life. For healthy older patients, age alone does not mean that they are at greater surgical risk. Older adults may take longer to recover from anesthetic agents. This is due to aging changes related to drug metabolism and elimination. Gerontological issues. Surgical considerations for the older adult. Older adults have a decreased ability to compensate for the stress of surgery due to declining physiological reserve, extra capacity of a body system or organ to carry out its function under stress. The risk for hemorrhage, anemia, fluid and electrolyte imbalance, infection, pressure injury, and acute kidney injury are increased in older adults. Nursing interventions before, during, and after the surgical procedure focus on reducing complications. Preoperatively, pad bony prominences to protect against pressure injuries and muscle and bone discomfort. Reassure the patient and family by teaching what to expect before, during, and after surgery, diet changes, description and length of surgical procedure, activities in the recovery room, pain management, coughing and deep breathing exercises, procedures, and treatments such as dressings and catheters. Intra Ensure preoperative screening has been completed. For example, blood work, radiographic studies, nutritional assessment, pulmonary function tests, and electrocardiogram. Intraoperatively, monitor patient for hypoxia or restlessness, hypothermia, hemorrhage, and balanced intake and output. Postoperatively, pain control. Provide adequate pain relief, so required postoperative activities such as deep breathing, coughing, position changes, and exercise can be performed more effectively. Respiratory function. Reduce respiratory complications by encouraging deep breathing and coughing. Perform after the pain medication has begun to take effect to encourage deep breaths due to less pain. Assess the patient carefully when giving narcotics because they can cause respiratory depression. Use a pillow and instruct the patient to hold it firmly over abdominal or chest incisions to support the incision. Taking a deep breath increases chest expansion as well as abdominal pressure, which may pull or stretch an incision. Older adults perform deep breathing and coughing exercise better if you perform the exercises with them. For example, say the following. Let's take a deep breath in through the nose, hold it, and count to 3, slowly blowing it out completely through the mouth. When you blow the air out, shape your lips like they are going to whistle. Mobility. Encourage mobility through the following nursing actions and observations. Use pillows to support the patient's body alignment. Assist the patient to ambulate as soon as possible after surgery. Regularly help the patient with passive or active range of motion exercises along with flexion and extension exercises for legs and feet. Monitor for unilateral swelling of the leg and calf or groin pain, which may indicate deep vein thrombosis. DVT is a risk related to venous pooling in the lower extremities. This risk is increased with postoperative inactivity. Assist the patient to change position at least every 2 hours. If patients lay in one position too long, pressure injuries can develop. When tissues are compressed between bones and the bed surface, blood supply is reduced to the tissue and cells begin to die. This can result in painful open wounds. Bowel function. It is common for patients to feel bloated after surgery. Increasing activity, such as walking, stimulates peristaltic action of the bowel. This helps expel flatus and reduce discomfort. Urinary function. Be aware of the following aspects of urinary function. Individuals often have difficulty emptying their bladder after surgery. Patients who are sleeping but restless should be evaluated for bladder distension. It is often difficult to void on a bedpan or in a urinal in a supine position. Older men with an enlarged prostate may have even greater difficulty voiding if they have received medications that have urinary retention side effects. Assisting patients to sit or stand to use urinals, use a bedside commode, or ambulate to the bathroom promotes bladder emptying and helps avoid the use of urinary catheters. Monitor urine amount, color, and odor. Older adults are prone to dehydration. Urine output provides an indication of their hydration status for intervention. Delirium. Perform the following nursing actions to minimize delirium. Monitor the level of consciousness routinely. Provide a calm environment and orient patients to their environment. Restraints should not be used because they can worsen delirium. Recognize that the presence of a urinary catheter can contribute to delirium. Avoid catheters if possible. Chronic disease. Chronic diseases may increase the patient's surgical risk. A medical clearance for surgery may be needed from the patient's healthcare provider, HCP. Emotional responses. The word surgery causes a common anxious emotional reaction in patients and their families. Anxiety is a feeling of apprehension or uneasiness resulting from the uncertainties and risks associated with surgery. Fear is the feeling of dread from a source known to the patient. Assist patients in coping with these feelings. If patients' fears are extreme, inform the surgeon. This includes the fear of dying. When a fear is excessive, the surgeon may reschedule the surgery until the patient is better able to cope. Surgical patients may experience various fears related to anesthesia, reversible loss of sensation. These fears include anesthesia awareness with general anesthesia, which is aware or conscious but not feeling pain during the surgery, feeling a loss of control or not waking up. The patient should discuss these concerns with the anesthesia provider. A growing trend is for surgery to be performed while the patient is awake. A form of anesthesia is used other than general anesthesia. Patients report feeling more comfortable when they are alert and aware of the surgical experience. It is normal for patients to be concerned about pain. The anesthesia provider gives medications for pain during surgery. Nurses give prescribed analgesics after surgery. Complementary techniques are also used to help reduce pain. These include guided imagery or focused breathing. Body image changes may be a fear for some patients. The thought of disfigurement, mutilation, bleeding, or having a scar may cause great anxiety for some patients. Allow the patient to discuss these fears. Nutrition. Patients should be well nourished to adequately heal and recover from surgery. Higher levels of protein for tissue repair and healing, vitamin C and zinc vitamin C is for collagen formation and zinc is for tissue growth, skin integrity, and cell-mediated immunity are required. Obese patients may have more delayed healing and wound dehiscence, which is the opening of the incision. Patients who are emaciated may have more infections and delayed wound healing as well. Smoking and alcohol and or drug abuse. Tobacco use and alcohol and or drug abuse increase the surgical patient's risks. Smoking thickens and increases the amount of lung secretions. It reduces the action of cilia that removes the secretions. Patients are encouraged to avoid smoking for at least 24 hours before surgery. If they have a chronic lung disorder, avoidance should be for 3 to 4 weeks before surgery. Not smoking increases the action of the lung's defense mechanisms, which makes more hemoglobin available to carry oxygen, which improves wound healing. Nutrition notes. Screening and nourishing the preoperative patient. And this is the top of page 174. Identifying and treating malnutrition before surgery may improve the patient's outcome. Unintended weight loss or decreased oral intake should prompt further nutritional assessment by a dietitian. Before elective surgery, the patients may have time to correct some nutritional deficiencies. If patients are overweight, they are often instructed to lose weight to reduce surgical risks, prevent respiratory problems, and promote wound healing. For anemia, an iron preparation may be administered. At least 2 to 3 weeks are required for objective evidence of the effectiveness of nutritional therapy. Before surgery on the gastrointestinal tract, a low residue diet may be eaten for 2 to 3 days to minimize bowel contents. The American Society of Anesthesiologists practice guidelines recommend a minimum of the following fasting time frames before anesthesia. Clear liquids 2 hours, a light meal such as toast with a clear liquid 6 hours, a meal containing meat or fat 8 hours. Clinical judgment is required regardless of the guidelines, which do not apply to patients with gastromotility or metabolic disorders, and also those with potential airway problems. Long-term alcohol and or drug abuse may cause nutritional deficiencies and liver damage. The damage can create bleeding problems, fluid volume imbalances, and medication metabolism alterations. In addition, alcohol and drugs that are abused can interact with administered medications and should be avoided before surgery for safety. Pre-admission surgical patient assessment. Non-emergent surgical patients have a pre-operative assessment. They have an interview with the anesthesiologist or a pre-admission telephone or face-to-face interview with RNs in the pre-admission testing department under the direction of the anesthesia provider. The interview process includes a health history, identification of risk factors, patient and family teaching, discharge planning, and necessary referrals to social workers, support groups, and educational programs. Personal or family problems with anesthesia or malignant hyperthermia are identified. Pre-operative diagnostic testing is based on the patient's age, medical history, assessment findings, and agency protocols. A urine or serum pregnancy test as appropriate for female patients may be done. This is to prevent fetal exposure to anesthetics. Health information and diagnostic testing results are reviewed by anesthesia providers. Abnormal test results are reported to the surgeon for intervention. Malignant hyperthermia, this is box 12.1 on page 175. Malignant hyperthermia is a potentially fatal hereditary muscular disease. It can be triggered by some types of general anesthetic agents and or succinylcholine, a history of anesthetic, a history of anesthetic problems in the patient or family members indicates the potential for this condition. Precautions can then be taken. A muscle biopsy diagnoses this problem. Surgery can be safely done with planning. The anesthesia provider carefully chooses the anesthetic agents. In malignant hyperthermia, metabolism in the muscles is increased. This produces a very high fever and muscle rigidity. In addition, tachycardia, tachypnea, hypertension, arrhythmias, hyperkalemia, metabolic and respiratory acidosis and cyanosis occur. Malignant hyperthermia is life-threatening. Immediate treatment is required to prevent death. Surgery is stopped. Anesthesia is discontinued immediately. Oxygen at 100% is given. The patient is cooled with ice and infusions of iced solutions. Dantrolene sodium, Dantrium, is a muscle relaxant that relieves the muscle spasms. It is the most effective medication for malignant hyperthermia. Dantrolene sodium is kept readily available in the operating room. It is given according to the treatment protocol of the Malignant Hyperthermia Association of the United States, which is mhaus.org. Table 12.4, preoperative diagnostic tests. Chest x-ray, the purpose is to detect pulmonary and cardiac abnormalities. Oxygen saturation is to obtain baseline level and to detect abnormality. Serum tests that are performed include arterial blood gases, and the purpose is to obtain baseline levels and detect the pH and oxygenation abnormalities. There's a bleeding time test to detect prolonged bleeding problem. A blood urea nitrogen can detect a kidney problem, and creatinine can detect a kidney problem. The complete blood cell count is to detect anemia, infection, and a clotting problem. Electrolytes you want to detect potassium, sodium, and chloride imbalances. A fasting blood glucose will detect abnormalities and also monitor diabetes control. A pregnancy test may be done to detect an early unknown pregnancy. A partial thromboplastin time will help detect a clotting problem, as will the INR, or the International Normalized Ratio. So that detects a clotting problem, and also that's to monitor warfarin therapy. The INR, or the International, oh, I said that one. Okay, so there's also another diagnostic test that may be performed would be the type and cross match, and that's to identify the blood type so that you can match blood in case you need to do a transfusion. There are urine tests that are also done, like the pregnancy test, that would be to detect an early unknown pregnancy, and also a urinalysis can detect infection and abnormalities for the urine. Federal law requires patients to be asked before surgery if they have a signed advance directive, e.g., healthcare durable power of attorney or living will for their medical record. See Chapter 17. Written information on advance directive is offered if they do not have one. Preoperative teaching. Preoperative routines. Preoperative teaching for common surgical routines includes date and time of admission and surgery. Admission, for example, arrive about 2 hours before surgery for preoperative preparation. Length of stay, and items to bring and wear, recovery after surgery, family information, for example, the waiting area and communication, the discharge criteria, for example, a responsible adult will be needed to take the patient home after outpatient surgery. Preoperative instructions and preparation. Special preps are explained. Nasal cultures for Staphylococcus aureus screening and treatment may be done. Bathing or skin preps to reduce skin bacterial counts before surgery are explained. Their purpose is to reduce surgical site infections. Enemas are ordered before abdominal or intestinal surgery to empty the bowel. This reduces fecal contamination intraoperatively. It also prevents distension or straining postoperatively. Medications to take the morning of surgery are explained. They can be taken with an ounce of water. Food and fluids are restricted before surgery to reduce the risk of pulmonary aspiration during surgery. The minimal fasting time guidelines of the American Society of Anesthesiologists are listed in nutrition notes, screening and nourishing the preoperative patient. Patients may brush their teeth or rinse their mouth without swallowing. Surgery may be canceled if the patient has not stopped eating or drinking as specified. Instructions for postoperative care are given before surgery This allows the patient to be alert for the teaching and have time for practice. Patients are informed that active participation in postoperative care helps their recovery. Patients are taught how to report their pain level using a pain rating scale. See Chapter 10. Pain relief methods are described. They can include parenteral or oral analgesics, an epidural catheter, or patient-controlled analgesia, PCA. Anticipated dressings, tubes, casts, or special equipment are also described. If needed, crutches are fitted to the patient. Their proper use is explained and demonstrated. Post-operative exercises are taught to decrease complications. They include deep breathing and coughing, use of incentive spirometry, leg exercises, turning, and how to get out of bed. After an exercise is taught, the patient is asked to perform a return demonstration. This allows the nurse to evaluate if the exercise was done correctly. Deep breathing expands and ventilates the lungs to prevent atelectasis. Atelectasis is the collapse of alveoli in one or more areas of the lung from hypoventilation or mucus obstruction. It reduces the lung's capacity to oxygenate the body. To deep breathe, teach the patient to sit up, exhale fully, take in a deep breath through the nose, hold the breath and count to 3, and then exhale completely through the mouth. This should be repeated hourly while awake in sets of 5 for 24 to 48 hours post-operatively. Incentive spirometry can be ordered to prevent atelectasis. It increases lung volume, alveoli expansion, and venous return. All patients can benefit from incentive spirometry. Keep the spirometer at the patient's bedside to use. Do not store on the windowsill or in a drawer where it cannot be reached by the patient. Offer it to the patient as ordered to ensure that it is used. Teach patients to do the following. Sit upright at a 45-degree minimum, if possible. Take 2 normal breaths, then put the mouthpiece of the spirometer in the mouth. Inhale until target designated by the spirometer light or the rising ball is reached, and hold breath for 3 to 5 seconds. Exhale completely. Perform 10 sets of breaths as ordered. Coughing moves secretions to prevent pneumonia. Reinforce teaching on how to cough effectively if not contraindicated by the patient's condition, such as a hernia repair or a head injury. Give pain medication before asking the patient to cough. Reassure the patient that coughing should not harm the incision. Splinting the incision with a pillow may be comforting. Several sets of coughing are performed every 1 to 2 hours while the patient is awake. Leg exercises and foot circles should be done every hour while awake. Ensure they are not contraindicated. Leg exercises improve circulation. They help prevent emboli formation. Teach patients to do the following. For leg raises, lie down, raise leg, and bend leg at the knee. Flex foot, extend leg, and lower it to the bed. Do 5 for each do sets of 5 for each leg. For foot circles, raise a leg slightly off the bed with the toes pointed. Draw a circle in the air with the great toe. Rotate to the right 4 times and then to the left 4 times. Repeat this 5 times and then repeat with the other foot. Table 12.5, teaching patients teaching patients coughing techniques. Procedure: have the patient sit up and lean forward. The rationale: promotes lung expansion and ability to generate forceful cough. Then show the patient how to splint the incision with hands, pillow, or blanket. This reduces incision pressure so it does not feel as if the incision is opening. Have the patient inhale and exhale deeply 3 times through the mouth. This helps expand lungs. Have the patient take in a deep breath and cough out the breath forcefully with 3 short coughs using diaphragmatic muscles. Then have the patient take in a quick deep breath through the mouth, cough deeply, and deep breathe. Okay. Generates a forceful cough and expands the lungs to help move secretions. Reinforce teaching that turning from side to side in bed is easier if the leg that is to be on top is bent. Then place a pillow between the legs to support the top leg. Unless contraindicated, have the patients use the bed's side rail to pull themselves over to the side. To promote comfort, have patients deep breathe while turning instead of holding their breath. To make it easier for patients to get out of bed and to reduce strain on the incision, instruct patients to turn on side without pillows between knees, place hands flat against the bed, push up while swinging legs out of the bed into a sitting position. Sit for a few minutes after changing position to avoid dizziness and falling. Deep breathe while sitting to expand lungs. Nursing process for preoperative patients. Data collection. This is on page 177. Health history. Patient data are collected on admission. Table 12.6. Have patients wear their contact lenses, glasses, or hearing aids to ensure accurate communication. Note the patient's emotional reaction to surgery previously discussed. Medications. All prescription and over-the-counter medications are reviewed. Herbal remedies or recreational drugs are reviewed. Anticoagulants such as warfarin or Coumadin or non-steroidal anti-inflammatory drugs, NSAIDs, including aspirin, may need to be stopped several days before surgery. This is done to avoid bleeding problems during surgery. Herbal medicines can interfere with other medications. They can also increase bleeding times. G's cause bleeds. Remember that. Patients may be told to stop specific herbal medications 1 to 2 weeks before surgery. Patients with diabetes who take insulin are given instructions. They are ordered to either hold their insulin or take half of their normal insulin dose on the day of surgery. After admission, blood glucose monitoring is done every 4 hours or as ordered. This ensures blood glucose levels are maintained within a desired range. Patients on chronic oral steroid therapy cannot abruptly stop it. This is true even when they are taking nothing by mouth, NPO. Circulatory collapse can develop if steroids are stopped abruptly. The surgeon should order a parenteral route for the steroids. Make sure parenteral steroid therapy is continued while the patient is NPO. Patients should be asked about their use of alcohol or drugs. This includes cocaine, marijuana, or opioids. These drugs can interact with anesthesia and medications. To obtain honest, accurate information, tell the patients of this potential interaction. Information and questions should be stated in a non-judgmental manner. For example, ask, "Oh, how much alcohol do you drink daily or weekly?" instead of, "Do you drink alcohol?" The first question assumes that people drink alcohol. This allows the patient who does not drink alcohol to indicate none. The patient who does drink alcohol can state an amount. They don't have to say yes and then give an amount upon further questioning. More accurate responses are given as this approach is viewed more positively by the patient who drinks alcohol. Another example would be to ask the patient, "What roles do drugs or alcohol play in your life?" Physical assessment. A physical assessment of body systems is performed. This information can identify risk factors for surgery and interventions to reduce them. Report a cough, cold, or fever to the surgeon. Surgery might be delayed until the acute infection is gone. Document dentures, bridges, capped teeth, and loose teeth. They can become dislodged during endotracheal intubation, insertion of a breathing tube for general anesthesia. Nursing diagnosis, planning, and implementation. Anxiety or fear related to potential change in body image, hospitalization, pain, loss of control, and uncertainties surrounding surgery. Expected outcome. The patient will state reduced anxiety or fear before surgery. Inform patients about procedures and surgical routines, which helps reduce anxiety. Allow patients to express their concerns to allow inaccurate information to be corrected. If patients express extreme anxiety or fear, inform the surgeon because complications or even death could result. Provide the opportunity to listen to music or use guided imagery, which can help reduce patients' anxiety and fears. Table 12.6, Nursing Assessment of the Preoperative Patient. Subjective data, health history questions, demographic information, name, age, marital status, occupation, roles, condition for which the surgery is scheduled. Why are you having surgery? Medical history, any allergies, acute or chronic conditions, current medications, pain or prior hospitalizations? Surgical history, any reactions or problems with anesthesia, any previous surgeries? Tobacco use, how much do you smoke? Pack year history, which is the number of packs per day times the number of years that they smoked. Alcohol use, how often do you drink alcohol? How much? Drug use, do you use recreational or street drugs? Coping techniques, how do you usually cope with stressful situations? Support systems? Family history, hereditary conditions, diabetes, cardiovascular or anesthesia problems. For female patients, the date of the last menses or period, and obstetrical information. Objective data, physical assessment, vital signs, oxygen saturation, height and weight, emotional status, calm, anxious, or tearful, neurologic, ability to follow instructions, skin, color, warmth, bruises, lesions, turgor, dryness, and mucous membranes. Respiratory, look for infection like a cough or breath sounds. Chronic obstructive pulmonary disease, respiratory rate, pattern, and effort. Barrel chest. Cardiovascular, angina, myocardial infarction, heart failure, hypertension, valvular heart disease, mitral valve prolapse, heart rate and rhythm, peripheral pulses, edema, jugular vein distension. Gastrointestinal includes bowel sounds, the date of the last bowel movement, abdominal distension, firmness, osteomy. Musculoskeletal deformities, weakness, decreased range of motion, crepitation, gait, artificial limbs, and prosthesis. Deficient knowledge related to the lack of previous experience with surgical routines and procedures. Expected outcome. The patient will demonstrate understanding of surgical information and routines before surgery. Consider patient anxiety levels before providing explanations because learning can be affected by high anxiety levels. Identify knowledge deficiencies with patients so they are motivated to learn. Reinforce preoperative information and new information as teaching is caring in action and empowers patients to be a participant in their care. Include the patient's family or caregivers in teaching sessions so they can assist patients through the surgical experience. Use a variety of teaching methods, for example, discussion, written materials and instructions, models and videos, and individualize explanations to allow for different learning styles and aging changes. Document teaching and patient's understanding as proof of teaching and the patient's level of understanding. Now we're going to watch this YouTube video.
As you proceed, help alleviate your patient's apprehension by orienting her to her surroundings.
Now, after surgery, you will have some pain.
I know.
We're going to go ahead and start an IV.
It's your responsibility to offer preoperative teaching at each step. Make sure the patient understands what's going on, what will happen after surgery, and what's expected of her. Tell her how her pain will be controlled as she awakens from anesthesia in the post-anesthesia care unit. Explain what kind of post-operative exercises she'll need to perform in order to heal as fully as possible.
I see that the surgeon has already been in,
Yes, he has.
and he signed the informed consents with you.
Ensure that the surgeon has obtained informed consent.
No, we understand the consent.
Okay. Now, do you have any religious practices that we need to honor?
Take this time to bring up any sensitive issues, such as the patient's religious practices. Check the patient's medical record and review or complete the preoperative checklist.
When was the last time you ate or drank?
About 8 o'clock last night.
Okay.
Ask her when she last had anything to eat or drink.
I'm going to go ahead and walk you over to the bathroom so you can change into a gown.
Okay.
Any other last-minute questions?
Then ask her to remove all of her clothing, including her undergarments, unless some other arrangement has been agreed to, and put on the hospital gown with the opening in the back. Encourage the patient to void at this time. Then instruct the patient to remove all hair pieces, hair clips, or pins and similar items, and put them in a bag. The patient will also need to remove her jewelry, including any body piercings. Makeup, nail polish, and acrylic nails are usually not permitted either.
Okay,
Thank
come with
you.
me. Mrs. Taylor, were you able to get all your belongings into the bag?
Yes, I did.
Help the patient remove any prosthesis, including dentures or other oral appliances, glasses or contact lenses, artificial limbs or eyes, and false eyelashes. Hearing aids can be removed just prior to going to surgery.
We'll leave those in for now.
Okay.
We'll take them out at the very end, right before you go down. Are you okay if we give your belongings to your husband for safekeeping?
That's fine.
Document the location of all items you remove. If the patient gives you any valuables that can't be immediately turned over to a family member or significant other, have security put them in a locked area and ask the patient to sign a release form if your agency requires one.
What we're going to do next is get your IV started. We're going to start some IV fluids, keep you hydrated.
Explain that you're going to insert an IV to keep her hydrated and give her medicine. If the healthcare provider has ordered anti-embolism stockings, help the patient put them on. If ordered, administer preoperative medications at this time.
Okay, they're going to be up in just a little bit to get you.
Oh, already?
Yes, already.
Considerations for the older patient teaching sessions. Environmental considerations. Comfortable and safe, anxiety-free, quiet, appropriate temperature. Correctly lit, small, intense lighting with non-glare, soft white light, not fluorescent. Private, no distractions, and no background noise. Presentation considerations. Identify readiness to learn. Plan learning based on current knowledge. Use past experience and relate to new learning. Use simple, understandable words and avoid medical jargon. Use legible audiovisual materials, e.g., large print, black print on white non-glare paper. If using colors, remember that older adults see red, orange, and yellow best. Blue, violet, and green are more difficult to see. Perform ongoing assessment of energy level of patient. Answer questions as they occur. Presenter considerations. Have a positive attitude and belief in self-care promotion for older adults. Earn trust by being a credible, positive role model. Maintain a professional appearance. Use knowledge of aging changes in presentation. Sit in front of patients for best visibility. Speak slowly in a low tone. Ensure that prostheses are in place, such as glasses and hearing aids. Allow patients increased response time and use memory aids, such as pictures or diagrams. Use touch appropriately to convey caring. Teach most important information first. Present one idea at a time. Provide instruction using multiple senses, vision and hearing. Provide repetition and obtain feedback to ensure comprehension. Provide feedback and positive reinforcement. Evaluation. The goal is to decrease anxiety. The goal to decrease anxiety is achieved if the patient states and demonstrates that anxiety is relieved. The goal for increasing knowledge is met if the patient is able to correctly state or accurately demonstrate the information presented. Preoperative consent. Before performing surgery, the surgeon must obtain written informed consent. It gives legal permission for the surgery. Consent has two purposes. One is to protect the patient from unauthorized procedures. The other is to protect the surgeon, anesthesia provider, hospital, and hospital employees from claims of performing unauthorized procedures. Informed consent is needed for all invasive procedures. These include surgery, anesthesia, blood administration, and radiation or cobalt therapy. Consent is typically valid for 30 days after signing. Informed consent involves three elements. One, the surgeon must explain in terms the patient understands about the diagnosis, the proposed treatment, and who will perform it, the likely outcome, possible risks and complications of treatment, alternative treatments, and the prognosis without treatment. If the patient has questions before signing the consent, the surgeon must be contacted to provide further explanation to the patient. It is not within the nurse's scope of practice to provide this information. The consent must be signed before analgesics or sedatives are given. Patients must demonstrate to a witness that they are informed and understand the surgery. Consent must be given voluntarily. No persuasion or threats can be used to influence the patient. The patient can withdraw consent at any time, even after the consent form has been signed. It may be your role to obtain and witness the patient's or authorized person's signature on the consent form. As the patient advocate, ensure that the patient signing the consent form understands its meaning. Ensure that the patient has no further questions to be directed to the surgeon and that the consent is being signed voluntarily. If the patient is unable to read the entire consent to the patient before it is signed. Patients can't give consent if they are unconscious, mentally incompetent, or minors. They also cannot give consent if they have received analgesics or drugs that can alter central nervous system function within time frames specified by agency policy. Consent may be obtained in any of these cases in person or by phone from parents, next of kin, or legal guardians as specified by law. A court order can also be obtained in a medical emergency. If time does not permit this, the surgeon documents the need for treatment in the medical record as necessary to save the patient's life or avoid serious harm, according to state law and institutional policy. Nursing care tip. Your signature as a witness on a consent form indicates that you observed the informed patient or patient's authorized representative voluntarily sign the consent form. It does not mean that you informed the patient about the surgical procedure. That is the responsibility of the surgeon. So we are at the top of page 180, preparation for surgery, and I am going to end part 1 here, and we will start part 2 on page 180, preparation for surgery.